So today I will be discussing the disproportionate impact that COVID-19 had on black and ethnic minorities in the COVID lockdowns from 2020 to 2022. From a physical, financial and mental standpoint, black and ethnic minorities were all hit significantly harder than the white majority. For example, financially, minorities were forced to deal with 0-hour contracts, meaning less financial support. Physically, they were hit with higher hospitalisation rates and higher mortality rates. And from a mental standpoint, they had a lower quality of life with less access to resources and often less access to education. It's really important to say that a lot of the issues that we will discuss throughout this presentation have been around for a really long time, and these inequalities have always been here, but they've just been highlighted and accelerated by the pandemic to show how unequal our society is for black and ethnic minorities. This presentation will discuss in depth the effects that poverty and the level of deprivation in an area you live has on risk factors contributing towards COVID-19 and how this can affect the way that you live during the pandemic, as well as directly affect infection rates, hospitalisation rates and mortality rates. For example, having access to less resources or less financial support in an already struggling environment. The figure that is most groundbreaking for me is that BAME populations make up 3.8% of our society. However, 5.8% of COVID-related deaths, meaning they are nearly 2 times more proportionally represented in COVID deaths than they are in England and Wales. 2/3 of healthcare worker deaths were from ethnic minorities, and on top of this, the first 11 doctors to die were from ethnic minorities, which begs to ask the question, what went so wrong in the NHS? Tim Cook, professor, looks at the deaths of 106 healthcare workers, 63% of whom were from ethnic minority backgrounds. Cook suggested that the reason for such high numbers of BAME deaths in the NHS could be due to lack of guidance for doctors and other NHS staff, or due to lack of rigorous PPE use in wider and less intense circumstances, for example, dentists, opposed to ICU staff. Public Health England was commissioned to do a review on the circumstances after seeing data like graphs like this one. This shows the hospital deaths by ethnicity in England up to the 21st of April, and in the y-axis shows white to be the 4th highest ethnicity by deaths, but it is the largest majority in Britain. However, it is important to note that large majorities of white elderly people do reside in care homes and presumably would have therefore died in there. That could explain the lower numbers of white deaths. In 2020, the Centre for Disease Control found that 2 times as many black and Hispanic people are more likely to be hospitalised than are proportionally represented. Also, the Office for National Statistics found that black people were 4 times more likely to die from COVID than white people in England and Wales. COVID-19 has an array of different susceptibilities that are all influenced by social determinants of health, risk factors, and they're all linked and codependent, meaning there's so many contributing and driving factors as to why some people are more likely to be infected or more likely to become more seriously ill from COVID-19. Firstly, I'm going to speak about neighbourhood, and how the effect of living in a built-up or poverty-stricken area is objectively bad for your physical well-being. Although the rent prices in places like Tower Hamlets or Newham are more appealing, the lack of green space, the less access to healthy food, and more pollution contribute badly towards health and be real contributing factors towards having type 2 diabetes or asthma. These diseases are comorbidities which are real and serious risk factors for COVID-19. BAME populations are 2 to 4 times more likely to contract type 2 diabetes, and the onset of type 2 diabetes in BAME groups is also 10 to 12 years earlier. Being economically unstable during the pandemic and having a family or yourself to provide for would have been really hard, especially for many BAME groups and people in poverty who were employed with 0-hour contracts and casual work in agencies or delivery drivers, etc. For these people, it was much harder to gain financial support when all the shutdown sectors were closed, i.e. restaurants, non-essential shops. Also, having less access to resources, for example a car, may have meant having to use public transport, and also being in a overcrowded housing, which made it impossible to social distance, especially for multi-generational families. There is also proof to show that BAME groups were fined more frequently, less fairly, and with higher amounts. Being economically unstable also probably meant that many households and employers/employees were less likely to self-isolate if they felt they may have COVID-19. Moving on to employment, many BAME populations are in lower skilled occupations. For example, black African men were 7 times more likely than white to be care workers, which was an occupation which was nearly impossible to socially distance in. Dr. Nagpal states, those working in a cashier come into close contact with 100 plus customers a day. Due to the nature of this job and being unable to work from home, these key workers were in contact with more than 100 customers a day in vast comparison to office and other workers who could work from home from the safety of their desks. Also, key workers' children still came into school, which encouraged more mixing with other people instead of social distancing. There is a direct correlation with high death rates and low skilled occupations. Language barriers meant that many were not receiving first-hand advice and could have received this from family and friends. Also, government guidance was not tailored. It was a one-size-fits-all approach, and racial distrust made it hard to collect data. Many people have tried to attribute the reasons and the why BAME people had such an unequal impact of COVID-19 to behaviour and rituals of BAME people. However, it is truly the result of systemic racism and structural issues in society that has caused deprivation. It is really hard to argue the genetic argument when Cow et al. 2020 removed and controlled comorbidities and employment, and there was a much smaller difference in mortality and infection rates. For possible policy responses, I think the government should try and take some accountability and some responsibility for what happened and how they need to act moving forward. Also, trying to tailor different approaches to suit different people and understand the population and the audience's needs, rather than one-size-fits-all old systems and approaches. One option could be universal credits, helping people to escape poverty by improving the use of credits to help the poor, so people are no more worse off than they was when they was on tax credits. The reform of the benefits and tax credit system in 2018 has made it more streamlined and more simple. However, people are in poverty even when they are working and are finding it really hard to survive. Reforming the universal credits would surely help lift the burden off of poor and working class people. People have called for further privatisation of the NHS in order to increase profits and lower taxes. However, the Health and Social Care Act of 2012 has meant that increased private investment of the NHS has made it harder for black and ethnic minorities as well as poorer people to gain access, and this problem would only increase with further privatisation. Reforming the tax system, addressing tax issues to lift burden off of working class by raising corporate tax, addressing tax havens, and issuing policies for tax transparency would surely also help the working class with their finances, alike to the universal credit system. Reducing economic instability would have a knock-on effect for both poverty and health in the United Kingdom. A further idea is educational campaigns looking at the bigger picture and tackling systemic racism and social disparities, trying to educate children on a new society without discrimination, so that there are less disparities in care for black and ethnic minorities, and they feel they have wider access to all the resources of the country, including community systems, healthcare, etc. A further possible policy response would be to enforce more data collection so that more and accurate studies could be carried out in the future. For example, enforcing ethnicity data collection on death certificates would have increased the data and studies that have been conducted on the COVID and black and ethnic minority link to such a serious extent. I think that the government should choose to pursue the policy of reforming the universal credit scheme so that poor people have less of a burden on them and are less likely to be in poverty and therefore more likely to be in good health.